Hello, everyone, and many thanks again for asking me to present this topic on PNH, but predominantly focusing on old versus new complement inhibitors and the real world versus real and potential benefits and risks associated with this. So, PNH is a disease characterized with chronic hemolytic anemia with paroxysms, with complement-mediated hemolysis, predominantly intravascular or only intravascular in untreated patients, with a propensity to thromboembolic disease, which is the reason for the mortality and morbidity, and as a link with underlying bone marrow failure, with nearly 80 to 90% of patients having evidence of aplastic anemia or MDS or other types of bone marrow failure. And this sort of helps to delineate these patients into either hemolytic, thrombotic, or AAPNH. This is quite important because the treatments and the therapeutic landscape for these patients could be different. So what's the pathophysiology of hemolysis in PNH? We know that terminal complement inhibitors, as marked by CD55 and 59, protect the red cells from the complement activation. And we all know that complement is always active in our body. And whenever we have PNH cells, and there are millions of them when you have a patient with PNH, because we produce millions of red cells every second. And in PNH patients, these do not have the complement regulatory proteins. And we know complement is always active, and this leads to hemolysis of the PNH red cells, leading on to all the complications related to PNH. So when we come to treatment, why do PNH patients need treatment? We all know that because patients with PNH can die due to the mortality related to the thrombotic complications of treatment. And this is a treatment which can be life-saving for these patients to prevent patients from getting vicious thrombotic complications. Which patients need treatment? We know that not all patients with PNH need treatment with complement therapy immediately. So it's a question of timing of treatment and the appropriateness of first-line treatment, and also monitoring due to treatment. And we'll touch upon the newer therapeutic regimens and the right time to treat treatment. So this is the pathophysiology of the disease. We talked about it earlier with uncontrolled complement activation. And this is what we are trying to inhibit, and thereby the life-threatening complications. The historical treatment options of PNH are illustrated there, targeting against the hemolysis, but quite ineffectively, trying to treat the thrombosis, again, quite ineffectively, but also improving the underlying bone marrow failure, sometimes effectively with these treatment regimens, but not targeting the PNH. So there is so much to be done in this area of hemolysis and thrombosis in PNH, because we know that despite warfarin being used in patients with a large PNH clone, there is still patients who have primary prophylaxis with warfarin or newer anticoagulants, but develop thrombosis at any time point, because you're not targeting the pathophysiology of the disease, because you're just giving them second primary prophylaxis, but not preventing the complement activation seen in these group of patients. So hence, I wanted to touch upon earlier on the transplantation in patients with hemolytic PNH. This is a data nearly 10 years old, but still important data, because it looked at 211 patients in the EBMT cohort over a long period of time, with these three different subgroups of patients with types of PNH, either thrombotic or AAPNH, or ones associated with recurrent hemolysis, with different overall survival and outcome. But not only that, not only survival, but also significant risk of complications due to morbidity due to acute and chronic GVHD as well. So what Regis and the colleagues compared was trying to look at the cohort of patients who were transplanted for their thrombosis. This is a cohort of patients who did not have a transplant in the French registry, and did a matched pair analysis. And if you look at patients who are thrombotic, if they were transplanted, they had an extremely poor prognosis compared to patients who did not have a transplant. And this is the data from pre-eculizumab era as well. So there's not impacted by anti-complement therapy. So we tried to look at our cohort of patients who received eculizumab but had to have a transplantation due to their aplastic anemia. And again, this group was associated with a median overall survival of around 70% at 2 years, with a median follow-up was 25 months, with a transplant-related mortality due to infections and veno-occlusive disease. So although transplantation is feasible in this group of patients, but predominantly done in this group of patients due to their AA, rather than due to their PNH, but still the outcomes are not as great as we showed for purely aplastic anemia without hemolytic PNH. So hence the rationale for blocking C5, because eculizumab we know binds to high affinity to C5, blocks the terminal complement cascade, and abolishes or no membrane attack complex activity, and the proximal functions are left intact. And we know that eculizumab significantly reduces intravascular hemolysis. This is data showing from TRIUMPH, both from the placebo and the eculizumab arm, and then once the patients crossed over, significant reduction in their LDH, with nearly 90% of patients having a reduction in their LDH after initiation of treatment. And a number of other studies are indicated there as well. So some of the indications for therapy in UK are it should be transfusion dependent due to the hemolysis and due to the PNH. If you're independent of transfusion, you should have a thrombotic manifestation related to PNH, or have complications due to hemolysis or pregnancy, or hemolytic PNH with symptoms associated with hemolysis, high LDH, and with agreement of the multidisciplinary team between Kings and Leeds. And some of the exceptional cases we will think eculizumab would be considered appropriate. And we all know that the clinical efficacy of eculizumab in patients with PNH in clinical trials have shown reduction in hemolysis, reduction in the need for transfusion, nearly abolishment or abrogation of the thrombosis, improvement in fatigue, and also reduction in the renal complications. But more importantly, improvement in the survival of this group of patients as well, because compared to the historical cohort pre-eculizumab, where for nearly 30% of patients died by 5 years of diagnosis, we know that nowadays with anti-complement therapy, these patients have a normal life expectancy similar to age and gender matched population. And not only that, when you look at the patients treated with eculizumab, it needs to be closely monitored, because there are a group of patients, not just due to the anti-complement therapy, but due to the natural progression, natural course of the disease, are able to have clonal remission, which can be seen in around 5.6% of patients. And just for example, this patient had started at a granulocyte clone of around 100%, but over a period of time, the clone size decreased, that it went below an arbitrary threshold of 10%, and we were able to successfully stop the eculizumab and monitor it. So it's not always a lifelong therapy. Spontaneous remissions can be seen as well. And very rarely you can see that onset of PNH hemopoiesis can improve the normal hemopoiesis seen in the context of underlying aplastic anemia. This is a slide courtesy of Lucia Lusarta and Professor Peter Hillman, showing that in the days of hamsters, that you see a patient becoming hamsters positive, i.e. getting PNH, transfusions getting better, with improvement in hemoglobin, platelets, and the neutrophils as well. So very occasionally this can happen as well. And important things to monitor for these patients, or these patients need to be monitored for meningitis, because these could be fatal if not treated in a timely fashion. So we tend to use prophylactic penicillin at a higher dose of 500 twice a day. We vaccinate them against ACWY and also against serotype B, and we do a number of educational activities to improve the understanding and also understanding of this and early treatment of this. And this is data from the pharmacovigilance analysis, looking at both pregnancy and also looking at the safety data of eculizumab, predominantly around meningococcal cases, that there has been 76 cases reported in this data, including 8 fatal cases in the PNH setting as well. So it's important that these patients are monitored for these and educated against the risk of meningitis. So what else happens during the treatment of C5 inhibitor, predominantly eculizumab? So this is something we are all as a community talking about in the last many years. Yes, eculizumab is a fantastic drug. It is a C5 inhibitor which prevents thrombosis, improves quality of life. But a proportion of patients, depending upon various literature, remain anemic or have a low hemoglobin level whilst on eculizumab. And some of them are transfusion independent, most of them are transfusion independent, while around 20 to 25% are transfusion dependent with varying levels of hemoglobin. So as part of the EBMT group of PNH physicians, we started to look at this, trying to categorize just hematological response to eculizumab, not other types of response, just hematological response. How is their hemoglobin, retic count, and their transfusion status? And we were able to divide into 4 broader groups of transfusion independent and no anemia, independence and anemic, occasional transfusions, and regular transfusions. And this is in the initial 6 months after eculizumab, first 12 months, and the last 6 months after being on eculizumab. This was a large series of around 150 patients, and we were able to find out that about 21% of patients are transfusion independent with no anemia, 40% are transfusion independent with anemia, and a proportion, around 30% occasional transfusion and around 12% regular transfusions. So the question is, what can we do to improve these group of patients? And these transfusions could be due to a number of reasons. One could be due to breakthrough intravascular hemolysis with reappearance of hemoglobinuria, reappearance of symptoms, increase in the LDH, and reduction in the drug level. And we know that in UK, at least about 20% of patients are on a higher dose of eculizumab to prevent this phenomenon of breakthrough hemolysis. And what else happens? What could be the other reasons for eculizumab not being super effective? One of the reasons, which is quite rare, is this variation seen at the site of C5, which makes it resistant to eculizumab or stops the binding of eculizumab to the site. And that is quite an uncommon phenomenon, but can be seen in some populations as well. So we know that once eculizumab binds to C5, the proximal pathway is left intact with the amplification loop going, and the PNH red cells getting coated or decorated with C3d degraded fragments, which can be seen in flow cytometry. And this leads to these cells being taken up by the reticuloendothelial system in the liver and in the spleen as well, inducing extravascular hemolysis. So these are some of the unmet medical needs in patients still treated with C5 inhibition. Could it be incomplete C5 inhibition with breakthrough? Could it be extravascular hemolysis? Could it be underlying bone marrow failure? And number of other factors, including access and lack of approval and difficulty in infusion. So why do we need newer complement inhibitors? We talked about better control of terminal complement inhibition, prevention of extravascular hemolysis, safety in all patient groups, including in pregnant, better modes of delivery, and one of the major bugbears is cost and availability. Although eculizumab is approved in a number of countries, it's only available in around 40 out of the 197 countries, and more drugs and more competition will definitely bring the drug prices down. But important point to note is any complement inhibitor should not worsen the underlying bone marrow failure or increase the risk of infection, or should not be less effective for thrombosis. So if you look at the pathway, can we target C5? Can we target C3? So one of the first drugs I want to take upon is this long-acting C5 inhibitor called ravulizumab, which has got high affinity to anti-C5 monoclonal antibody. It's derived from eculizumab through targeted engineering, enhances the FC receptor recycling, increases the half-life, and maintains a favorable safety and tolerability profile. So this was the first data, which was in the patients who were naive to complement inhibitors, comparing ravulizumab and eculizumab, and again showing the non-inferiority of ravulizumab. This is looking at in patients who were prior treated with eculizumab and comparing them with ravulizumab, again showing a non-inferiority for eculizumab. But one of the main things is ravulizumab prevents PK breakthrough hemolysis. So PK breakthrough hemolysis is due to inadequate drug in the system. As you could see, the PK, this complement C5 levels, is all over the place in a proportion of patients with eculizumab, while it's tightly controlled with ravulizumab achieving a sustained inhibition of serum free Phi so that it does not induce PK breakthrough hemolysis, i.e., there is no hemolysis due to inadequate drug in the system. But there is still pharmacodynamic breakthrough despite presence of adequate levels of drug in the system, which is what is indicated here in the data which was published last year as well. But patients obviously do prefer, why don't they have 6 to 7 infusions in a year rather than 26 infusions of eculizumab? So that had a significant impact on the patient's perception and the quality of life as well. So it is an important landmark or an important improvement in this. So ravulizumab has been used in subcutaneous form as well. This is a early data from this phase 3 randomized study looking at to see if subcutaneous ravulizumab also achieved a complete free C5 inhibition, and indeed it did. What are the other complement C5 inhibitors? One of the agents is crovalimab by Roche Pharmaceutical, which is also an engineered C5 monoclonal antibody, looking at the total C5 concentration in healthy volunteers, treatment naive, and eculizumab pre-treated patients. But essentially, this data, which was published a couple of years or a year back, now showing that both in treatment naive patients who are 10 and patients switching from eculizumab with 19 patients, looking at the hemoglobin levels, which were increasing in the naive patients and stable in the switch patients, with reticulocytes being adequately controlled at the initial phase and then stabilizing on it. And a few patients had C5 polymorphism. So the two of the trials which are ongoing, and I'm aware Argentina is part of the Coordinador 2. This is looking at patients previously treated with C5 inhibitor, predominantly eculizumab, but there is also a descriptive arm who are on ravulizumab or higher doses of eculizumab, or the phase 3 Coordinador 2, which is looking at patients naive to C5 inhibitor, which is what I think is ongoing or due to start in Argentina, comparing crovalimab with eculizumab. Interesting thing is IV initially, and then it's 4-weekly C5 inhibitor self-injected by the patient as well. There are a number of other agents as well, but some of them are not taken forward. This was one of the agents which we used many years back, but it's now coming back in combination with a C5 inhibitor. This is a siRNA targeting C5 through GalNAc conjugation, and it seems to have a very good early data, which is called cemdisiran. There are other agents which is Coversin, which is completed phase 1, phase 2 clinical trials, but I don't think so. Phase 3 trials have been taken up. It's given once a day subcutaneous infusion derived from a deer tick. And this was one of the data published in a couple of years back, looking at a patient who had a polymorphism, who was resistant to eculizumab, but treated with Coversin with a very good improvement in the LDH and the quality of life as well. Biosimilars are very, very important. So these are some of the examples of some of the biosimilar trials. One of the trials we did is just completed on ABP 959, which is an Amgen biosimilar. This is the Samsung biosimilar, which is also, to my understanding, is finishing clinical trials with different types of regimens. So there are a number of agents which are used in the anti-C5 agents, which are indicated there. Some of them are small molecules, small peptides, siRNA, some of them are antibodies, most of them are antibodies as well, as indicated in this data. But is targeting C5 the only thing, or should we be moving up into targeting C3. And it's also important that when we look at patients who are on C5 inhibitors, be it eculizumab or ravulizumab, we just need to look to see what is their LDH control. Is it reduced? Is it less than 1.5 times the upper limit of normal, or is it more? If it's unchanged, you need to look for C5 mutation. But if the LDH is more than 1.5, then you need to see, is it due to adequate amount of drug in the system, the pharmacokinetic breakthrough, and that needs to be looked at as well. But if the CH50 is normal, then you would want to look for increasing the dosage of the drug. But if the CH50 is less than 1.5, then we look at a hemoglobin to look at a satisfactory response, or whether you would see symptomatic anemia. Then you would look at the reticulocyte count before making a decision on what are the reasons why these patients are still having high retic count and still are anemic, plus or minus needing transfusion, but this could be multifactorial. So one of the other agents which is quite interesting and recently approved by approved in FDA is pegcetacoplan, which is published in NEJM as well. So this is results of the Pegasus, which is a C3 inhibitor, comparing it with eculizumab in a randomized 1:1 fashion in patients who had prior eculizumab, looking at twice weekly IV subcutaneous infusion of this drug compared to continuation of eculizumab, and there was a difference of mean hemoglobin change as indicated above, with 16 weeks data in patients who this was the period when they had both the drugs on the system, and this was the time when it was just pegcetacoplan with maintenance of the hemoglobin, while patients who switched back to eculizumab alone had back to their baseline. And this was the data presented again at the 48-week efficacy data, showing that patients who were on eculizumab switched back to combination of eculizumab and pegcetacoplan, and then maintained on pegcetacoplan with a good improvement in hemoglobin. But one of the important things to note in the study is the increased risk of discontinuation, risk of breakthrough hemolysis because of a large red cell PNH clone. So again, this needs to be looked at before making clinical judgments on what line should be used. But there is an upfront study as well, which to my knowledge has completed enrollment, and they wait for the results of this with comparing APL2 with no drug as well. So this is a few C3 blockers, and one of the broad C3 blockers is pegcetacoplan. So what's the data for other proximal component inhibitors like factor D and also factor B inhibitor, because factor D is a rate limiting critical step in the alternate pathway with an extremely low plasma concentration, and then the blockage of this blocks the amplification loop and thereby inhibiting the downstream complement cascade as well. So there were 2 trials which have been now published, one in Hematologica last year, looking at this drug called danicopan in untreated PNH patients, and there were 10 patients, and again showing a reduction in the LDH, improvement in the mean hemoglobin. But also when this drug was used in combination with eculizumab in PNH patients already on eculizumab with variable doses, we were able to show that in these 10 patients that all but one patient needed 1 episode of transfusion compared to multiple episodes of transfusion in the past. And this has now been taken into a phase 3 study, which is looking at danicopan as an add-on to C5 inhibitor, either that or with placebo, with a double-blind placebo-controlled study, with all patients switching back to danicopan after 12 and 24 weeks respectively. One of the other agents which has been quite impressive in the phase 2 data has been this drug called iptacopan in patients with PNH with active hemolysis. And interestingly, on addition of this drug, the LDH remarkably improved, but patients were able to come off their eculizumab. And when it was published that 7 out of 10 patients stopped, but now I'm aware that all patients have stopped eculizumab with continuation of this factor B inhibitor given 200 milligram orally, with number of transfusions pre-study or 1 year before study, and none of these patients receiving transfusion. And this is the Apply PNH study, which is ongoing, which is the phase 3 study, comparing continuation of C5 inhibitor in patients who are anemic compared to switching them to single agent factor B inhibitor in the form of iptacopan, which is LNP023. And the upfront data was also presented by Professor Jung-Ho Jan from Seoul, looking at the first line treatment of iptacopan, smaller number of patients, but quite remarkable, reassuring data as well. So again, I would say that there are a number of agents which are there, including a novel C5, broad C3 inhibitors, factor D, factor B inhibitors, including a compound called Biocryst, which is also a factor D inhibitor, which is ongoing, which has completed phase 2 trial, and phase 3 data is ongoing. So we know that there are a number of agents which can be number of pathways which can be targeted in the setting of PNH, and it's important to look at the upcoming data and also to see how these drugs could be used either in combination or in upfront setting or in number of different settings as well. So I think to conclude, I would say that most patients, if there is a possibility of enrollment into clinical trials, should be considered for clinical trials, either at the outset or in countries where there is no access to C5 inhibitors, potentially into clinical trials, or at the time of inadequate response to approved C5 inhibitors. And this is some of the proposed algorithms based upon their underlying bone marrow failure or hemolysis and the disease activity as well. So lastly, I just want to thank the people who are part of the PNH service at King's and in Leeds as well. And to summarize, I would say PNH is still the most vicious acquired thrombophilic state. Eculizumab was made for PNH, and we've treated a number of patients in the service, but still there is unmet clinical need, both in the eculizumab and in the ravulizumab era as well, and how we can use these novel anti-complement therapies, which are in early and late phase clinical trials, and also important to understand about clonal regression, because that would mean that we'll be able to cure these group of patients. I think with that, I'll stop and happy to take any questions after other presentations as well. Thank you.